Well, we might get underway. Welcome to you all to this part A of the RACGP Standards for 5th edition and accreditation. I'm going to get you to all come off mute one by one in a moment and introduce yourself to me and get you to answer a couple of questions, because I think it's important that I get an understanding of who you are, what you are, and what level you are at in relation to your accreditation process. So, you know, this is the icebreaker that we've got to get rolling with. So for people who don't know me, my name is Gary Smith. I'm a practice manager of 36 years, a very large general practice at the foot of the Blue Mountains, west of Sydney. I had hair and it was black when I first started in as a practice manager all those years ago. But I've been a surveyor for AGPAL for 22 years. And I normally train the surveyors accordingly, and have been part of the writing of the standards with the college over the years. I was on the college expert standing committee for about 6 years, and I was in the writing of the 3rd edition and part of the 4th edition. I'm a director of AGPAL. I'm on the board of AGPAL, and I'm chair of QIP. Some of you may know one of the subsidiary companies of AGPAL, Quality Innovation Performance. I'm on the board of my local PHN, and I'm on the board of the local health network, or the local health district, with all the public hospitals. Plus, on the board of Health Workforce Tasmania, which is the Commonwealth Government Rural Workforce Agency as well. Active practice manager. I've got a 12 doctor general practice, something like 7 nurses, and reception staff to boot from there. Now, this is 2 hours long. You know, I can talk for 2 hours. If people who knows me, I can talk for 30 hours, but that's not what this is about. This is really about you getting to understanding in relation to the standards. Yes, and if you've gone through the 4th edition and you haven't been through the 5th, yes, there are some sizable differences. And today, this particular presentation, part A, is about orientation to the standards and the surveyor process. Parts B and C is where we're going to get into the finer details around each of the criteria that are significant between the 4th and the 5th edition. We will take a break around the 10 o'clock mark. 10 o'clock your time mark, which is 11 o'clock my time. We'll take a break for about 15 minutes when we get halfway through that as well. I'm going to be asking you to be part of a couple of the questions I'm going to ask today. If I'm going to ask questions, if you want to come offline, or I'll specifically ask someone if they've got any views on it. You would have received a workbook today, and there was some pre-work required in the workbook, that was only received today, so that pre-work you wouldn't have done. The reality is that for parts B and C, the workbook is going to be required accordingly. Now, the PowerPoint presentation today is actually reflected in the workbook. AGPAL and the PHN will decide whether they're going to send you these slides for the day, but they don't really need to, because these slides are actually in your workbook. Acknowledgement, Northern Queensland PHN and AGPAL acknowledges the Aboriginal and Torres Strait Islander peoples as Australia's First Nation peoples and the traditional custodians of this land. We respect their continued connection to the land and sea, country, kin and community. We also pay our respect to their elders, past, present and emerging, as the custodians of knowledge and law. Well, I've introduced myself, and thank you very much for introducing yourself as we virtually went around. I have a bit of a passion for quality. I'm an international surveyor for an organisation called ISQA, who accredits the accreditors around the world, and they're based in Ireland. And like AGPAL has to be accredited accordingly. And my role as a surveyor is that I go in and accredit these organisations around the world. It's great for tripping around. You know, sometimes I'll have to 4 trips around the world a year to various countries doing the accreditation, which is normally about a week on site. But of course, COVID shut all that down. And I've just finished a virtual an accreditation with 2 other surveyors for Malaysia, for an accrediting organisation in Malaysia. I've just been appointed to an executive board of the Asian Society of Quality of Healthcare. So I've got a bit of a passion for quality. And I suppose that's the challenge with accreditation, is that why do we do accreditation? And I suppose that when we do accreditation, there's 2 components to it. Accreditation allows you to gain access to government incentives, but it also allows you to sit back and reflect upon the quality improvement of your particular practice which you work in. We're going to think about accreditation. A lot of people think about accreditation as a one-off every 3 years. And it becomes a project once every 3 years. I challenge you to think about that, because we should start to integrate accreditation and the standards into business as usual, rather than one-off every 3 years. Let's start to think about how do we require and fit the accreditation into our day-to-day life in running an effective quality practice. So this is a series that AGPAL has produced on behalf of your PHN on high-performing primary care series, it's called. And I think you've already done one of the series already, and that was with Paresh, I think. Series topic 1, continuous improvement and practice incentive payment quality improvement. Session 2 is the STAR, which is today, and there are 3. There's part A, B's, and C's over the next 2 Wednesdays as well, and hope to have you on board for those. And then the 3rd in the series is population health and digital literacy, and the 4th is around integrated care. So they're the overview of the series which has been put together. So in this particular series, these 4 topics, and of course the 3 we are going to do in this particular series, it's the training and support your PHN has put together it's really around the fact of workforce capacity. And I think the challenges in rural and remote Australia is all around workforce capacity. So hopefully the series I put together will help you manage the workforce that you struggle to deal with in relation to fly in, fly out, the availability of professionals, skills accordingly. Some of you may have heard about the quadruple aim in healthcare. It used to be called the triple aim, but healthcare came along and they put another aim in it. And I'm assuming the quadruple aim, your PHN has spoken to you about what that means. The 3rd point in relation to the primary care series is what I've been talking about, embedding that culture for CQI. What is CQI? It's continual quality improvement. And what is culture? Culture is one of these things, you know, I have a very simple approach to it. It's the way we do things around here. And I think it's important, we need to start to think about how do I embed quality improvement into day-to-day business, of which accreditation is. Of course, now with PIP-QI, there are some requirements around quality improvement, which is required for one of the conditions of PIP-QI. So there is a considerable amount of quality improvement processes identified in the 5th edition, which we'll go through them as well. I think that another reason why they put together the series is around digital literacy and data engagement. Who would have thought that last week I did 29 hours of Zoom meetings and Skype meetings with breakout sessions, etc., etc., etc. Who would have thought, you know, 12 months ago would have been like that? So digital literacy in our day-to-day life is going to form part of being our day-to-day life. Data engagement is we really need to think about, because that box, the black box that sits in that cupboard on that shelf in that room with all the information in it is so critical in relation to the management of our patients' health. So that's why we've got to think about this thing called rubbish in and rubbish out. The data engagement component of high-performing practices will be a very interesting one. Of course, I think the challenge for us all is sustainable primary care. How sustainable is primary care for us? And part of accreditation is around sustainability of primary care. And I think the series that the PHN has put together bases around that. I'm doing a presentation on November 12th at the AAPM's virtual conference on adaptation and innovation in primary healthcare. And in that, I'm going to be talking about sustainability. And of course, I think integrated care in the region is critical in relation to the ongoing management of patients' care. And the challenge you've got in rural and remote is that how do I link with all the other parts in the patient's journey? And patient-centered care is so important. For what it's worth, in my PHN and my local hospital boards, I've been appointed as the chair of the Joint Integrated Care Subcommittee, which is bringing integrated care from primary health care and the acute sector together and try and find ways and means by which we can start to think about the integrated care with both organisations working together, because we're all there for one reason, and that is in relation to the journey of the patient. So, what are we looking at? Growing your expertise. This is the first part. This is webinar A. And I suppose that one of the things I would like to say first up is that you need to understand who owns the standards. The standards are actually owned by the Royal Australian College of General Practitioners. They are the standard setters. And as you know, we're up to the 5th edition now. If anyone's been online as long as me, if we remember back in the 80s, that purple coloured book that was sent to every general practitioner that was draft standards, and GPs looked at it and practice managers looked at it and said, no, that's not for here, we'll chuck it on the coffee table. So who would have thought from about 1986 all the way through now that we are at the 5th edition, and accreditation is part of doing business. Remembering the college owns the standards. So what's AGPAL's role in this? AGPAL's role is to assess against the college standards. AGPAL does not own the standards, does not write the standards. It is only assesses against the standard. Is accreditation mandatory? I hear that question quite often. The answer is no. Accreditation is not mandatory. But as I said to you before, being accredited allows you to gain access, if you wish, to get Commonwealth Government incentives like the PIP, PIPQI, the WIP accordingly. You may find this hard to believe, but there are practices out there who are accredited, but for whatever reason have not decided to take any incentives from government. They're using straight as an incentive, a marketing incentive accordingly. So let's have a look about this particular webinar series. So we spoke about the total series put together, the 4 topics. What are we going to talk about today in relation today, next week, and the week after? Well, we're going to take you through the key changes between the 4th and the 5th edition, and there are a number of key changes. There are sizable key changes. It's a different way of doing things, and I think for the better, and we'll talk about that in a moment. And we're going to discuss the criteria for meeting the intent of indicators within the 5th edition. There are certain words that you'll walk away with today, which are critical words, and the first critical word is the intent, and we'll talk a little bit more about the intent. We're going to talk about developing a self-assessment method to identify areas where your practice does or does not meet the standards for general practice. We're also going to look at an approach to meeting compliance with mandatory and aspirational indicators. They're 2 new words, mandatory and aspirational, which are different to the 4th edition. May mean the same, but they are 2 new words we've got to get used to. And I suppose the last one is really about for you to look at ways and means by which you can provide the appropriate evidence to actually meet the intent of the indicators. This last dot point changes the focus of accreditation. And this is, if anything you walk away with today, this is the last dot point on the slide is the key to the process of the 5th accreditation. I won't go into too much detail about each one of those, but we'll address each one of those over the next 3 webinars. So today, part A, this is the agenda. There was a pre-assessment activity in your workbook, but I believe you only got your workbook this morning. So you can reflect upon those pre-assessment activities after today's presentation. I suppose that we're going to need your activity book for parts B and C. So just make sure that you have it available, and you may have done some work on it as required for parts B and C. We're going to talk about what you need to know about the orientation of the standards, and we're going to take you through the process today of understanding intent and also intent of indicators and what's the best evidence that you need to meet the intent of the indicators. We're also going to then look at the surveyor process, looking at it from my side as a surveyor, looking through my eyes, from what I may need to get from you in relation to meeting the intent of a survey visit. And then we'll go through and we'll come up with some key point summaries and some questions at the end. If there's any questions as we go through, please put them in the chat room box, so I can answer them as we go through, or I just might come off mute and ask someone, with anyone want to come off mute and answer some questions for me. What do you need to know? Well, half the battle of accreditation is knowing the standards and what they mean. The 5th edition standards have been written in plain English, and my first advice to you would be sit down on one Saturday afternoon for an hour and a half and just flick through the standards to get an understanding of the structure of the standards, because the standards will actually give you the answers that you need for meeting the respective indicators. The 5th edition have been structured very, very well. So start to think about getting that book, which can be downloaded from the RACGP website, and start to work with that document there. In relation to today, just some targeted tips for you as we work through the presentations the next 3 weeks. This particular symbol on the screen, the outside symbol with the internal yellow and the dot in the information, this is about tips and guidance. When you see this slide come up, you'll be able to, this will be, you're going to require to understand this particular indicator, because it'll be important for you to use the information on that slide for accreditation purposes. So that's an information slide for you. When you see that comes up, you need to take a little bit more notice, because that particular slide is about interpreting the standard, which will be required for your accreditation accordingly. Why did the college actually write the 5th edition standards for general practice, which is slightly different to the philosophy behind the previous standards? So when they were putting them together, they looked at, they wanted to look at improving the quality and safety in general practice. This is quality and safety, A, for the practice itself, and B, for the care that they deliver to their patients. And also, it's a very good document for doing a gap analysis. Remembering that accreditation is very big at looking at systems and systems development, systems engineering, and systems management. Now, I'm a great believer in systems, because it's everyone doing the same thing. Well, hopefully that's the case. But it's a very good document for identifying any gaps within system and processes within your practice. What I'd like to do now is provide you a visual orientation of the differences, the main differences between the 4th and the 5th edition. So what's an animation look like? On the left-hand side of the screen, you will see where it says 4th edition. The 4th edition was very process focused. very process focused. And I'll give you an example of a process focus. Now, this refers to the specification of exactly what and how a practice has to meet the indicator. So in the process, it said, our practice has a documented system to identify, follow up and recall patients with clinically significant results. On the 4th edition, it was very process. You actually had to have a documented system that says, how to identify, how do I follow up, how do I recall patients with clinically significant. It told us what it specifically had to do. Process focused. The 5th edition now talks about outcomes focus. And what the 5th edition says, it's giving you the power to decide what evidence that you need to meet the indicator. So what does an outcome focus for clinically significant results mean? An outcome focused is our practice recalls patients who have clinically significant results. Now, it doesn't tell us how to do that. The 4th edition tells us we have a documented system, identify, follow up and recall. The 5th edition says, hey, you recall the patients who have clinically significant results. So the difference, it's a big difference. Now, trust me, when the 5th edition came out, as a surveyor and as a director of AGPAL, as a practice manager, remember I'm all those, I see things from different lenses. And I thought to myself, practice managers love to be told what they have to do. Give me a cheat sheet, give me a tick box. Yes, I've got that piece of paper and it says this, etc., etc., etc. Well, in the 5th edition, hey, that's not required. There's no cheat sheets. There's no mandatory piece of paper required. In the 5th edition, it says patients recalls patients with clinically significant results. It is up to you, the practice, to tell me, the surveyor, how you do that. So I thought about this in the 5th edition. I said practices and practice managers will struggle with this. Hello, surveyors will as well, because this really puts a challenge back on surveyors to say, yeah, I accept that. No, I don't think it's good enough. We'll talk a little bit more about outcomes focus as we move through the presentation. But that's the critical difference, process to outcome. There are 2 main differences in the 5th edition Standards of General Practice. The colleagues have gone to a modular structure, a bit like plug and play actually, and the change of focus from process to outcomes. So in the new module structure, there are 3 modules in the standards. The first is the core, known as C. There is the quality improvement module known as QI. And there is a general practice module known as GP. So 3 modules that you'll actually see those, you'll see the Cs, the QIs and the GP. Each of the standards is divided into a series of criterion. And each criterion is divided into indicators, which provides the crux of the process of the assessment. Now read my lips or look at my eyes. The way to do accreditation is not start from the standard and work to the criteria and work down to the criterion. It's best to look at the criterion and work back. What do I need to do? What do I need to do? So when we're looking at the assessment process, let's think about the criterion, which is the critical part. What I'm going to do now, I'm just going to play you a video, which give you a little bit more overview in relation to the module structure of the standards. Well, there you are. I hope that slide, a little video there, puts into perspective the structure in a little bit more detail of the standards. Now, it looks complicated, but it's actually not when you start to work with it. I think Scott's comment at the end, indicators provide the crux of the process of assessment. So my advice to you when you're looking and preparing through, we'll talk about Accreditation Pro later on, we start at the indicators and work back from there. Does anyone want to come off mute and ask any questions around the structure of the standards? Don't be backward and coming forward. Do you think it's easier? Does it look easier? Does it look harder? Has someone started to play with them already? So just any feedback you may have in relation to the structure of the college standards. Anyone got any thoughts? Or not, or we can type something in the chat box if you want. Has anyone started to work with them at this point and have found them easy to work with? I suppose the advantage that AGPAL you've got if you're an AGPAL client, is the fact Accreditation Pro, which is your pre-assessment document, starts at indicator level, which makes it a lot easier in doing that. No one's got any comments? Nothing in the chat box? So there's some differences between the 4th and the 5th edition. In the 4th edition, we had flagged and non-flagged indicators. Remember those ones? Flagged were mandatory. We had to meet them. Unflagged indicators, we didn't have to meet those. And we, as a surveyor, we'd sit back and possibly look at doing some CQI, some continual quality improvement around those particular indicators. But in the 5th edition, there are mandatory indicators. This relates to the old flagged indicators, and these are indicators to be found that you must meet. And you need to meet these particular indicators to meet the accreditation requirements. So this is a must. Indicators with that particular symbol next to it is a must. So one of the first words you need to remember is intent. The second word now is a must. Now, in relation to aspirational indicators, this is where there's no symbol next to the criterion. And it says aspirational. In aspirational, it means we'd like you, or the college, not AGPAL, we'd like you to aspire to meeting those particular indicators. If you don't, that's fine. They're not mandatory. They're not a must. So you may get some CQI, a recommendation from surveyor around aspirational indicators. But remember, mandatory indicators are the old flagged indicators. And every time you'll see an indicator, which I'll show you in a moment, next to an indicator, that would indicate that that particular indicator is a mandatory indicator. So not only are there symbols, there are also colours that you need to start to think about in the college standard. Under each meeting each indicator, there is a blue font. I'll show you these in a moment. So if the text is in blue font, this is where evidence for that particular indicator is a must, and that is a mandatory. So when you see an indicator in blue, or if you're colourblind like me, it'll be in red. Ha ha. And that's why they put the mandatory symbol in there for people like me. You need to actually have. It's a must. You must provide evidence for that. The black text below, which we'll show you in a moment, below the "you must" is a suggestion of how you would meet that indicator. That's the second word. Third word you need to understand is the coulds. So we've got the intent, the musts, and the coulds. So when you get a "you must," there then will be some black text that says, which will show you some options how you could meet the requirements of the indicator. Now, this is the great thing about the 5th edition. They give you examples in each of the indicators of the "you coulds." what could I use as evidence in meeting the you must? Now, the you coulds, as it says on here on the slide, could be exhaustive depending upon the nature of your particular practice, and will the nature and size and distribution of your particular practice. What suits your practice, which differs, of course, from a solo GP to a corporate GP to a group GP to an AMS. Every one of those practices operates differently. So the evidence which is provided by practices, depending upon your structure of your practice, is the you could. I'll give you an example on this one. I was doing a survey in rural New South Wales 18 months ago. Solo GP. GP was heading for retirement. His wife was a receptionist. He only had about 2.5 years left to retire. So I spoke to him about his business plan. And we'll talk a bit more about the business plan later on. So he took me into the staff room and he had a whiteboard up there. He had 3 things on his whiteboard. 1, look for a locum for more time off for me. 2, try and find a buyer of my practice. And 4, in retirement, looking to look after nursing home patients in nursing homes. Did I meet that criterion or not? What do you think? Where it says you must have a business plan. Did I accept that? Does someone want to come off mute and tell me yes or no? And if why? There's no. So what do you think? Think about that solo GP and the whiteboard, 3 things written. Someone want to type a message on it, or someone want to come off mute and have that, give me some thoughts around that particular scenario? Did I meet the indicator or not? So anyone want to help me on that? Anyone want to come off mute and have that discussion with me? What your views may be? Or someone type something in the chat box? Surely someone out there that may have a view in relation to what my decision was or could have been, what may be the options on that. Anyone at all? Lisa? Any views or thoughts on what that scenario may be? Did I accept that particular whiteboard as meeting the indicator of a business plan?
Gary, it's Janine here. I'm
Yes,
thinking
Janine,
that he had the intent there and he thought it through, but he probably needs to formalise it. So I don't know in terms of what evidence you need.
Look, I think you've hit the nail fair on the head, Janine. See, once again, it's up to me as a surveyor to whether I accept that or not. Now, one of the things surveyors have got to think about is the fact that I, as a practice manager, being around for 36 years, when I do a business plan, right, it's got everything in it that's required to be in it. It's got to be documented. I've got to have reviews, action plans, outcomes, etc., etc. That's for my practice, which is a very busy. I've got 9 owners here, just had 10 owners. So I'm accountable to 10 owners. I cannot overlay as a surveyor what happens at my practice over anyone else's practice, because that's in excess of the standards. So you need to think about in this, the you coulds. I accepted that. I accepted that because the intent was correct. Solo GP, rural area, 1 receptionist, which was his partner. That's neither here nor there. He wrote 3 things that he wanted to do in the last 2 years of practicing medicine. So I met him. I met him with that indicator. So when we're talking about here, the you coulds, we need to start to think about there is a litany of you coulds that you've got in your practice that could substantiate the you musts and substantiate the intent. So I think it's important that start to think about the you coulds in your practice that would meet the indicator. Now, we're going to talk a little bit more about the you coulds and the you musts in a moment. So here's an example of blue text. Let's take you through this. Here you are. You've got criterion C, which is the core module. Standard 6, criteria 4, mandatory indicator F. So that's how it works. C 6.4 F, core module, standard 6, fourth criterion, indicator 4. It's in blue. So what's blue say? Blue is a compulsory, it's a you must. Now, the indicator says our practice has a policy about the use of emails. You notice this? Our practice has a policy about the use of emails. So we assume that you already got one. What's the you must in this? The you must is you must maintain an email policy. Now, what are the you coulds? What are the things that you may need to do? So there's the you must. It's a requirement that you must demonstrate to meet the accreditation against this indicator. Now, let's look at the black. The black here is the you coulds. What are the things that you have in relation to the intent of the indicator? I'll give you an example on this one. I did an accreditation about 2 years ago, just after the 5th edition came in, and it was down on the New South Wales Victorian border. And it turned up at this practice at 8:30. The practice manager runs in and said, "Oh, Gary," she's puffing and panting. "Oh, here you are. Here's my policy. Here's our policy on the use of email." And I said, "Mary, that's great. Thank you very, very much." She said, "Oh, look, I went to bed last night and woke up at midnight and saying, my God, I don't have a policy on email. I better do one." So here she is. She presents it to me. And when I get to C 6.4 mandatory F, she had a policy. But was the intent right? I asked the question, who knows about the policy? She said, only you and me. Staff don't know about it? Oh no, I only finished at midnight last night. Did I meet her or not meet her on this one here? Anyone got a view? Anyone got a view whether she met this indicator or not?
No, she didn't.
Yeah, who was that?
Tanya.
Tanya, you're correct. You're exactly right. Because the intent wasn't there. Do you follow? So although you may have an email policy, the intent is and if you look at the standards, the intent is, well, is the intent being met? Do people know about it? So it's important that you coulds put it on your email, on your website. People do that. Some people put it up on the wall. Some people put the policy in a new patient form. These are things. These are the areas. I've got one, but how do people know about it? So this is what you need to do. What are the you coulds about this policy? So no, I didn't meet that because the intent wasn't there. The piece of paper was there, but the intent wasn't. So we touched on this before in relation to what are outcome-focused accreditation. The important thing about outcome accreditation, as I said, one size doesn't fit all when we're talking about evidence. It's important that evidence there's an understanding of everyone within the organisation about any evidence that you wish to utilise as the you coulds. Accreditation, the process of accreditation, especially with Accreditation Pro, is to involve the entire team of the practice. You know, up until about 2 accreditation cycles ago, I did everything. Practice manager did everything. But as time's moved on, the accreditation process has changed, and especially in the 5th now, where other people need to know, other people need to take ownership. We need to involve all our staff. So I'm coming up for the 5th edition soon. So my office manager, I allocated work across to her, my front desk team leader across to her, supervisory nurse across to her. Isn't Gary lucky? He's got all these people he can shoot it out to finish it off. Do you have that luxury? I don't think Michelle has. I think Michelle's only got her there, I think. She may have a receptionist. So involving other people in this process, because now other people are going to be involved in the interview processes accordingly, and they need to have an understanding of the extra evidence is required. The great thing about outcome focus, staff will provide you examples of the you coulds. So start to utilise your staff to provide the examples of the you coulds. So let's look at understanding the process from the surveyor's side if we need to determine whether an indicator is rated met or not met. Now, I gave you a couple of examples already around from the surveyor's lens on this. The important thing about a surveyor, and I trained AGPAL surveyors, that they must understand what intent is all about in the context of the criteria and the standards under which the indicators sit. Surveyors must consider whatever evidence which is put in front of them in relation to the intent. Because as I said before, every practice has different styles of intent, different styles of evidence that they can put together. But it's interesting to note that 99% of practices, as you'll see in a moment, still do practice information sheets, which we don't have to do. There's no requirement for a practice information sheet in the 5th edition, but practices still do it. And that's fine, because they do have a document to support the indicator. So that's one of their you coulds. So when we're thinking about surveyors, surveyors need to change their thinking as well around to the practices thinking. And it's up to you now, it's up to the practice now to convince the surveyor that the evidence that you put up in the you coulds meet the indicator. Don't ever be afraid, please, don't ever be afraid to have a discussion with the surveyor in substantiating your evidence. The challenges for you as a practice is to think outside the box in relation to the you coulds. And don't forget that you coulds for one indicator can be used as you coulds for other indicators. Could be across a number of indicators. So this is really important that you think about these you coulds. You can use as many you coulds as you want to substantiate, but think of the key you coulds. Now, when you, which you'll see in a moment, when you look at an indicator, it actually gives you the you coulds. If you go onto Accreditation Pro, for instance, if you're an AGPAL client and hover over the indicator, it'll tell you what are the key you could pieces of evidence that you would need to provide. So the you could evidence is in the college standards, and the you could evidence is in Accreditation Pro. Now, it is really important for you to get a good understanding, as I said, about the explanatory notes in the standards. Reading explanatory notes in the standards for each of the indicators, and it also gives you the examples of the you coulds. So in the explanatory notes, the indicators are based around from a quality and safety perspective. Meeting the criteria in the explanatory note is where the you coulds could be. Meeting the criterion in the explanatory notes actually gives you the examples of what are the you coulds for each of the indicators. And of course, in meeting the indicator in the explanatory notes, provides you optional ways your practice can choose to meet the intent of the specific indicator. So let's have a look at what this looks like. This is a diagrammatic slide on how standards are structured. So we have the standard, then we have the criterion, then we have the explanatory notes. And under each of the indicator, there is examples of evidence for the U-coulds to meet the indicator. So there is plenty of evidence there for you to be able to meet the indicator. So just to continue on in relation to the standards in another slide, this sort of shows you some of the couple of answers to my questions earlier on about my surveying process. There is the purpose of the standard, and in that there is explanatory notes of each of the criteria. It's the structure. Then what lays underneath that is the intent, and under the intent there are the you musts and there are the you coulds. It's up to you to work out what you will show as the you coulds to substantiate the intent of the indicator. The you coulds substantiate the intent of the indicator. So we're going to break for maybe sort of 15 minutes in a moment. But before we move on to the next section, so let's do a summary of the first part. We talked about the you musts, and these are ways a practice needs to evidence. The you musts are required by the practice to evidence how they have met the indicator, the intent of the indicator. The you coulds are possible ways the practice could approach fulfilling the guiding principles, or which is the intent. And the list of the you coulds are available on Accreditation Pro and this pre-assessment, or on the college standards under explanatory notes, or you can use your own specific approach to the you coulds. Now, before we break for a 15-minute break, do we have any questions or comments in relation to the first half of today? Please come off mute if you wish. If you've got any comments or questions accordingly, I'd be happy to hear them. Or if you need some validation on some of the information I've provided, I'm more than happy to do that. If you need some more examples at this point in time, I'm happy to do that as well. Or if you wish, during our break, which will come back around about 15:15, we'll take a break for 15 minutes. You can put those in the chat box and I'll address those when we come back. So if there's no one wishing to come off mute, I'll get you to put yourselves all on mute now, and we'll see you back here at 10:15 your time. Thanks very much. Well, it's 11:15. We are back now. Well, I'm back anyway. I hope you're all back. Look at the chat box. There's no questions in the chat box in relation to the first half of the presentation today. But if you have, just continue to put any questions in the chat box. Has anyone thought of any questions or comments in relation to the first part of this morning? They would like to make a comment on, or come off mute, provide some feedback accordingly. Thanks, Janine Cox. She says very informative so far. So has anyone got any comments? Make a comment in relation to. I'd like it if you have started to do your accreditation process within your practice. If someone wants to sort of come offline and provide us all with just an identification of what maybe some of the evidence that you've come up with in your practice, whether there's any evidence which is sort of very left field or outside the box because your practice is different. How are you finding all the you coulds? Has anyone sort of got any views or thoughts on how you are putting together the you coulds in your particular practice? Anyone from there? Lisa, in your role, what are you doing about the you coulds, the substantiation evidence? Lisa's had to step away. That's right, left a note there, sorry. Let's have anyone else? Meryl, what about you? Have you started to look at you coulds as yet? What sort of evidence that you're looking at?
So, I mean, this was done all earlier this year, so
Yes.
it's just a matter of revision now.
Good.
But I agree with some and disagree with others.
Oh, yes, yes, very good. And I think that's important, Meryl. I think sit back and review. And if you're using Accreditation Pro, of course, you have the ability to upload documents as well, which is really, really good for me as a surveyor. So my assessment can take place before I get there. So if you've got that ability to upload documents,
Yeah.
please do it. Did you do that?
Yes,
Meryl?
I have. Yeah.
Great. That is good. That is good. Anyone else would like to come offline and let me know how they're going with the UCUDs or the evidence? Because we're going to talk a little bit more about the intent in a moment. Are any of the Nicoles there? Anyone? Any of the Nicoles would like to come on? No? Righto then, we're going to now for the next sort of 45 minutes to look at a step-by-step understanding of the intent of indicators. Although we've spoken quite a lot about it already, and I suppose when we look at the intent, we've got to look at and say, what's the most appropriate bit of evidence that we could use? There is no use putting evidence up for the sake of the evidence, for the sake of doing it, because it could be inappropriate. I'll give you an example. There was one recently, although we'll talk about prescriptive evidence later on, it was about an infection control policy. Well, this practice uploaded one sheet on how to wash hands, but that's not what the indicator wanted, or the criterion what needed, or was the intent right? A one page on how to wash hands is not an infection control policy. So you need to start to think about what's appropriate for that particular indicator for the evidence at that point in time. So let's have a look. Let's look at a step-by-step interpreting of the intent and what's the most appropriate bit of evidence that you may need accordingly. So the first thing is you need to do is determine what is the RACGP stated importance of the indicator. We need to go back and look at the indicator. This is, you notice here, we've got the information symbol here. To determine the most important part of the indicator, the first thing you need to do is read the explanatory notes for the criterion, focusing on why this is an important section. So go back to the explanatory notes and read about the criterion. The next step is to make note of the specified quality and safety context of the indicator within the standards. Now, each of the standards is based around quality and safety. We said this right at the beginning. It was the framework by which the standards were written. So we need to think about, when we look at an indicator or the intent of the indicator, think about quality and safety. So what does that mean? So for you, both the introductory text from the standard combined with explanatory notes within the criteria are useful for putting a framework around the intent. An example would be, which we'll talk about in a moment, is the follow-up of clinically significant tests and results. Now that's framed around quality and safety. So what are the UCUDs with that? And we'll talk about what are the UCUDs for recalls of quality and safety. And the third, a third of the next important step for defining of intent is consider ways you are currently addressing the intent of this indicator now. It is important that a lot of not say nearly all, but such a high percentage of the, if not all, the documentation that you may have already in your practice would meet the intent of the respective indicators. So you need to start to think about the fact that investigate what you have already got in your current system as evidence for the UCUDs. And as I said, in step 3, in interpreting the intent, most practices already have the evidence already in their practice. The fourth one is consider the guidance provided in the standards as to what evidence can and should be used to meet the intent. Now, this is really important because under meeting each indicator, it gives you the direction of what you could use in relation to meeting the you musts. Actually gives you examples of what evidence you may need. So I keep going back to the importance of looking at the standards because they have your answers for you. Yes, as I said, if you're an AGPAL surveyor, you are going to actually have those you coulds or evidence provided for you that you can reference back. Another part of interpreting the intent is who should be involved in the process. As I've said previously, the importance of team. This particular set of standards are designed about team, not about individuals. It talks about the team in quality and safety. So the indicators talks about everyone being involved. How does the team? It doesn't say the doctor, doesn't say the practice manager, doesn't say the receptionist. It says the team. Even allied health is part of the team if they are involved in your practice. So it's about the team, and that's why it's important that in the accreditation process, the team are involved in putting this together because they are the ones that now fall into the requirements of the standards around intent. The sixth step is what's the best evidence that should be included by your practice to enable the most appropriate demonstrating of meeting the intent. Once you've identified the evidence that you may have across the practice, it's really important to say, what's the best pieces? What have I got? What's the best? Is there any gaps associated with that particular piece of evidence? And we'll talk a little bit more in a moment about what you need to do if there is a gap there that you need to address in the evidence which you have got. So let's go back to this particular indicator, which is C6.4. We know what that is. That's core, standard 6. Criterion 4, mandatory, indicator F. So what are these are the you musts. Maintain an email policy. That's the first part of this. Now, but you also must in this, which we spoke about before, is that just because you've got an email policy doesn't meet the intent. So if you go back to the explanatory notes, it actually says the practice team must be familiar with the policies, comply with them, and understand the risks associated with using email and social media. So there you are. Just because you got the piece of paper doesn't mean the intent has been met. If you go to the explanatory notes, it actually shows that there's a section out of it, what you need to do. I had a breach this week, I don't mind saying, in relation to email policy. A patient filled out a new registration form. The staff transposing the email left a letter out between the patient's two names. The doctor wanted medical information sent to this patient via email. The patient consented to it. It was sent out of the PMS system, but it ended up in America. And this person emails back and say, this is not me. I think you got your email address wrong. So I worked through it this morning, actually, before I came online. And sure enough, it was transposed incorrectly. Interesting in relation to what is our policy. There is a policy in place about the usage of email, but how do we work on the transposition of wrong emails? So I'll have to review that policy now to ensure that when the doctor speaks to the patient and the patient provides the email, that the doctor confirms in their system that the email is correct. Just don't send an email to the front desk staff saying, can you please send documents to Mary Jo, because Mary Jo's information in the PMS was incorrect. So even when we have email policies, we then got to check to make sure they're correct. So let's have a look at this particular component now of the intent of an indicator. So let's look at GP 2.2 mandatory B. So we're talking the GP module now, standard 2, criterion 2, indicator 1, and it is mandatory. And it is our practice recalls patients who have clinically significant results. This is from standard 2, as we said, comprehensive care, that's known as a standard in GP2. The comprehensive care in the standards is defined as our practice provides comprehensive care to our patients. Now the criterion, GP 2.2, is based around follow-up systems. So what we're going to do now is work through this particular indicator, criterion GP 2.2 mandatory B. Our practice recalls patients who have clinically significant results. So what's this look like? In the standards, there is, as you can see on the screen, an explanation. And the standards actually say about comprehensive care, which is standard 2, comprehensive care, goes through and indicates what is defined as comprehensive care. The scope of general practice is not limited by age, gender, body system, disease, or service site. As such, general practice spans across all these areas. So standard 2 is about comprehensive care in the standards, and they've given us an overview of what comprehensive care means. This is why it's important that we understand the philosophy behind each of the standards. This is about quality and safety. This is drilling it right down. So if you look at GP 2.2 B, our practice recalls patients who have clinically significant results. What part of that standard there I've listed would this particular indicator fit into, do you think? Anyone got any ideas? This is clinically significant results. You need to understand this is not about abnormal results. This is clinically significant. Well, I'm assuming it'd fall into prevention, may fall into management of acute, chronic, complex conditions. So as you can see, that particular indicator can fall into a number of the areas that are defined as comprehensive care. So let's look at this particular indicator in a little bit more detail. I've highlighted 2 areas of GP 2.2b. 2 important areas that you need to be mindful of. One is recall patients, and the other are clinically significant results. So why is this important? Why are follow-up systems important? But when we're looking at this particular indicator, there is broken up into a number of areas. Why clinically significant, as I've highlighted here? Clinically significant results need to be communicated quickly and appropriately, so appropriate action can be taken. Failure to recall patients may result in an adverse outcome. And of course, there are flow-on effects with that. So part of the intent of this indicator is around recalling of patients who have clinically significant results. So when you're looking for evidence based around GP 2.2b, what policy do you have in place, if it's a policy, around recalling of patients with clinically significant results? So now let's have a look at the requirements of GP 2.2. Our practice recalls patients. So remember we talked about the two outcomes focus, which is the 5th edition, due to process focus, which was the 4th edition. In the 5th edition, all it's asking you to do, as what the criterion says, you must have a process for recalling patients. A recall occurs when a GP decides that a patient needs to be reviewed with a specific period. In this particular case, in the 5th edition, you must have a process. Can someone either send me an answer, a comment in the chat line, or come off mute and provide me with some evidence, an example of an evidence where you would meet this particular indicator. Our practice recalls patients who have clinically significant results. Anyone got any ideas? What may be some evidence, some new coulds to meet this particular criterion? It's a pretty simple one, this one. Can someone help me on this? Chat box, or come offline and give me an example of what bit of evidence you may use for this particular criterion. If you don't know this one, you're in big trouble. Come on, someone come offline and provide me an example of what bit of evidence you would have to meet the process of recalling patients. No one's got any ideas? Really? What did you do? Yes, sorry, who's that?
It's Tanya. Is the evidence that they have the results that are adverse?
It could be the results, but the most important bit about this, Tanya, is just a policy, a written policy. So if you already have a policy in place for the 4th edition, which you all would have, that's your process. The policy is the process. So if you've already got existing evidence in your practice that shows a process, right? That's fine. It could be a flow chart. In my practice, I've got a flow chart of how we recall patients with clinically significant results. I do have a policy written as well. You go and speak to my chronic disease management nurses, or you go and speak to my nurses. They can tell you the process. So it is advantageous if you have a written document, but having a process in place, because what we as a surveyors will do, we will ask key people about the process. And if those key people say, this is what we do, well, there's your answer. The process is there. The intent is right, and people know about it. Is it documented or not documented? Well, that's the next bit accordingly. It doesn't need to be documented, but you'll get a recommendation around that. So as long as you have identification of a process, if you had a process already written for recall of patients with clinically significant results from 4th edition, there's your evidence for the 5th edition. So it could be as simple as that. You already have one in place. Part of your recall process, and we all do this as part of evidence, and here's a classic example, that you have a process in place. Part of evidence is induction. I know in my staff induction program and my registrar program, part of the induction program is how to recall patients. So there is a bit of evidence for you as well to say that there is a system and people understand it. So the induction process will also cover the recall system. There's a bit of evidence for the you could as well. So our practice recalls patients who have clinically significant results. And you could use, as I said in this, be explained in a written policy. Your practice can also document your recall system, as I said, in the induction program as well. So let's have a look at the next part of this particular criterion, clinically significant results. What's the definition of a clinically significant result? A surveyor cannot determine what's clinically significant. The individual doctor makes that call. You notice the second bit highlighted in yellow here? Clinically significant does not necessarily mean only abnormal results. You follow? Even normal results could be clinically significant as well. So when you're looking at 2.2b, clinically significant is not just about abnormal results. So if you actually have a policy in place now that is specifically around abnormal results, you may need to amend it to cover clinically significant results. So let's look at this clinically significant results. The GP makes a judgment as to whether information is or not clinically important for a relevant patient in the context of the patient's healthcare. While a GP will generally decide that an abnormal result is clinically important and requires further action, they also decide that a normal result requires further action. Just because a result is normal is not generally the end of the process. The result may be ruling out, but further testing is required. So review your policy on this. You will already have a policy in place, but this 2.2.b in the system you'll have, but thinking about now, if it's based around abnormal results, you may need to go back and change that. So think about that. Think about the changing of it. There's just been a comment in the chat box around, you know, most practice think about recalls around chronic disease management, because that's where our practices are heading, you know, looking after chronic disease patients, a better income stream, etc. But these are about clinically significant results. Make sure your policy reflects that. Now, when we're looking at this particular criterion as well, you need to think about the different types of follow-ups required as well. Does your system allow for different types of follow-ups? And when we're talking about clinically significant, we need to start to think about around, does our policy extend more than just chronic disease management unit, as what Janine just says. When we're putting our policy together, we need to think about all aspects of clinically significant results accordingly. So when we're thinking about a definition around clinically significant results, I think the last two statements are very good framework. The probability that a patient will be harmed or the seriousness of the harm. So when you're designing your protocols, think about what fits into clinically significant results. Now, this is a checklist that we can work through for evaluating whether the evidence you've got, which you've collected, will meet the intent of the indicator. The first one is that all elements specified as a must are required, and these are mandatory. So the first thing we need to, any musts, they're required. So you need to have evidence to meet the particular indicator. Some of the indicator elements, as you will see, are labelled as coulds. So there are options in relation to the different types of evidence which are required to meet the intent of the indicator. Both the must requirements and the could options, you select must as a combination evidence how the practice is meeting the intent of the indicator. So that particular checkpoint there is a fact of the evidence you have is meeting the intent of the indicator. Then it's up to the surveyor to make an assessment that the indicator which has been met, that there is enough comprehensive evidence. Now you need to understand, how does a surveyor survey? Well, that's interesting, isn't it? Let me tell you, the most important part of my surveying, and I tell my training when I'm training surveyors, is the walkthrough at the beginning. My survey begins when I phone you to say, hey, I'm coming to do your survey. It's Gary here. That's when my survey begins. I start asking questions at that point there. When I'm parked out the front, waiting for the next surveyor, my co-surveyor to turn up. But the most important part is the walkthrough. Because when walking through, I'm looking, I'm listening, and I'm asking questions. And the questions I'm asking you are about the intent of certain indicators. Cold chain storage, the cold chain management. I'll ask questions as I walk through. I'll say hi, I'll the receptionist, the nurse, the practice manager. I'll ask a series of questions to start to get an understanding with your knowledge of the requirements of evidence based around the intent of the indicators. So demonstrating the intent is important. Demonstrating can be by visual, by signs up, by talking, by other documentation around. Do you realise there's no requirements in the standards for a policy and procedures manual? No requirements at all. There's a requirement for policy, for a policy. Now, that policy can be stuck up on a wall, can be on the intranet, it can be in a book at the front desk, don't really care. There is no requirement for a policy and procedures manual. But of course, the PHN will always say, and I will always say as well, a policy and procedures manual is good governance. Now, if you go to the AGPAL resources, registry of resources, the resource site, so yes, there's a policy and procedures manual there. Just go through those and pull out the required policies required for accreditation purposes. Don't just give me the whole policy and procedures manual, which is 425 pages. Just give me the 6 policies which are required. And next thing it'll look at is how many coulds need to be included. Well, I suppose that the number of coulds will depend upon you know, what you think you may need to meet the indicator. If I as a surveyor don't think there's enough there, I'll ask you more questions, or I'll say, do you have this? Do you have that? And a surveyor will not leave your practice until they have covered off on every bit of evidence to ensure that you can support the musts in this. If they can't find something, they will ask, and if you can't produce, then that is a different kettle of fish. But we'll lead you in relation to what you may need to find. The RACGP have put together some clarifications, and I think these are important. We've touched a little bit on these earlier. The explanatory notes are so important. The musts are the things you need to do. The indicator is the most important part. Start from the bottom and work up. And meeting each indicator is where the UCOUDS documents are identified. We have mandatory. We've got the musts, the coulds, and now we've got ones called prescriptive evidence. And these are the ones that you need to provide evidence for, prescriptive evidence. Prescriptive evidence is around high-risk areas. In a moment, I'll take you through what one of the risk areas are in your practice. If someone wants to drop on chat with a chat line for me in relation to what you think a prescriptive, a high risk area of your practice, and what may be a policy which is required to address the high risk areas of practice. Prescriptive evidence must be provided to the surveyor of your practice to meet the requirements of the indicator. If you're an AGPAL client, these prescriptive evidence is uploadable, which is great before we get there. So prescriptive evidence, no one sort of dropped in the chat box yet. Maybe an example of a high risk area in the practice before I flick across to the next slide. A prescriptive indicator is this: GP module, standard 4, criterion 1, mandatory, indicator B. Our practice has a written practice-specific policy that outlines our infection control process on page 143 of your workbook. So how's that? A written practice-specific policy that outlines our infection control process. So there is a prescriptive indicator. It's about infection control process. What are the you musts on this? Maintain an up-to-date practice-specific infection control policy. Up to date means you've got to have one. What are the you coulds? What are the you coulds in relation to ensuring that you maintain an up-to-date specific policy? What can you show me? Well, if you've got a practice-specific infection control policy and you use the one from the Registry of Resources from AGPAL, you'll see down the bottom it's got review dates. Maybe showing the review date is a you could. It could be on a staff agenda once every 12 months, reviewing the policy. It may be an email to your supervisory nurse or to someone to say, you know, can you do some updates and follow through on what the new infection control requirements are from the college. Conduct regular audits, which I would assume in COVID period, we would have many examples where we've actually maintained our infection control policy. Think about it. Did we review it in relation to hand sterilisation or infection control or putting up barriers or whatever, putting markings on the ground? Yes. Wow, that's great evidence, isn't it? That is great. You coulds. Any emails, any memos to staff. So there are some you coulds, but this is a prescriptive indicator. Part of the college standards is really about patient-centred outcomes, and this is where we are moving to in relation to primary health care. Possibly our funding system is moving towards patient-centred care. You know, they're talking about voluntary enrolment and those other things which may come along with it. It's about patient-centred outcomes. Part of patient-centred outcomes is about engaging the patient in relation to the management of their own healthcare. And they are part of the team in relation to managing their health outcomes. When you look at the college standard, is that the patient-centred care encourages the whole practice team to keep a focus on the reason why the intent of the indicator has become central to the assessment process. So when we're talking about the intent of the assessment process, it's all based around patient-centred care. So when we're thinking about the intent, think about patient-centeredness. I've touched on some of these already in relation to surveyors' involvement in relation to the accreditation process. We assess, as I said, against the standards. We consider the evidence. We ask more questions if we need to. And we may need to investigate further in relation to whether you're meeting the intent of the indicator or not. We spoke about that earlier on. But there are a couple of key points you need to be mindful of this. The burden of proof in relation to meeting the indicator sits with the practice. You need to provide as much evidence that shows that you're not only meeting the indicator, but also meet the intent. But one of the things I want you to be mindful of is ensure that it's specific, it is specific to that particular indicator. Surveyors and practices should pre-select health records, which will evidence meeting the indicators. As we go through B and C, parts B and C, you will see how the medical records will form part of the UCOODs. You need to understand which the third dot point, which links with the first dot point. It's out of our scope to search your practice for evidence. You need to make it available. And I think that the last dot point is fair and reasonable. We need to be fair in relation to the opportunity for you to demonstrate meeting the intent of the indicators. That's why we might ask you for certain things as we move through the day on site. Have you got this? Can you talk to me about that? It may happen a couple of times because we can't find the respective evidence accordingly. And we've spoken about it's important that only align the evidence to the you musts accordingly. But at the end of the day, the surveyors are not there to not make it met for you. This is a quality improvement journey accordingly, and we'll do everything within our system to ensure when we walk away from there that the respective evidence has been provided accordingly. If we think that the interviews which we carry out are rehearsed or scripted, we will sort of ask other different questions to elicit any further information accordingly. We will ask you, can you show me how to do this? I'll give you an example on this. I'll ask a receptionist about cold chain management. Oh, yes. I said, what's your understanding of cold chain management? I write the temperatures down. Oh, do you? Yes. Yeah, twice a day. Where do you write those down? Oh, can you show me? Yes, there they are there. That's good. Oh, what happens if it's above 8 degrees or below 2 degrees? I don't know. I just write it down. Wow, doesn't that ring bells? And how often do I hear that? To the extent that I just write it down. They don't understand the complete component of cold chain management. They're processed in doing what they are told to do is write it down. So cold chain management, from front door all the way through to the fridge is important for everyone within the organisation. I'm lucky in my case here, my reception staff don't deal with the vaccines. My nurse is on from 7 a.m. to 6 p.m. every day, so there's always a nurse here that manages that. But staff are fully aware of cold chain. So, key points. The 5th edition are outcome focused, not process focused. And as I said, this gives you more ability to be flexible in relation to what evidence you may have specific to your particular practice or service to meet the indicator within the criterion. And yes, there will be differences in relation to your style of practice accordingly. When evidence which you provide must be in the context of your practice. So often that we see policies and procedures that are not specific to the practice. They download a policy and they don't even customize it to suit their practice. So if you're going to download a policy and procedure, say from Registry Resources or Cubase from AGPAL, please go through and where it says insert practice name, put your practice name in, because once I see a policy that has not been customized, you know full well that it is not, the intent is not there accordingly. You determine what the intent is, not me, not the surveyor, right? You do that by interpreting the criteria accordingly. Righto, there we have it. It is 3 minutes to midday. We've got some time for questions before I put on the last slide for where we go from here. There's been no questions come through in chat line, really, no comments. Really, this is all about you, it's not all about me. I'm here to help you. So some more interaction would be great on this, especially in part B and C, where I'm going to require some interaction from you in parts B and C. Any information, any comment you make, it is not stupid, it is not insignificant. It's important that you have your piece and have your say accordingly. So please interact where possible. Use the chat line, even if it's all okay, no issues, going on okay. If you can provide some feedback, that would be great accordingly. So has anyone got any questions about today before we wind up? Is there anything else you want to know? Anything for clarification purposes? Either put in the chat box now, and I'll attempt to pick it up before we finish up. Or so if anyone wants to come offline and make some comments or statements, or just how you felt today went, whether the information was enough information, too complicated, you already knew it, that's fine. But any feedback is important for us all on this, because the PHN wants you to get the most out of this particular series as well, because they want to support you in the accreditation process. Lisa, thanks very much for your comment about the workbook. I think it's important that you actually look at the workbook for part B and C. In relation to part B and C, we're going to go digging deeper into the core module in part B accordingly. So make sure you get the workbook. A couple of comments, Janine, is that Janine's made a comment. If you haven't got the workbook, please get in contact with her. It was only sent out this morning. It may be sitting on another email address somewhere accordingly. 4th of November, next Wednesday, we're back again, 9 to 11. And as I said, we'll talk about digging deeper into the core module, into the criteria and the indicators which are new in the 4th edition, in the 5th edition. Now, on AGPAL's registry of resources, there is a document there that aligns the 4th and the 5th, and maybe some of the things you may need to look at for the 5th edition. It's a great mapping document. It's the mapping between the 4th and the 5th. If you don't have it, maybe Janine or whichever Nicole wants it, they may have it available at the PHN. They can provide to as well. For me, the first thing I'd be doing would be looking at that mapping document to say, what do I need to do for the 5th edition? So thanks very much. If there's no questions accordingly, I thank you for your time. I'll let you go back to your busy day schedule, and we'll then catch up on Wednesday the 4th, next Wednesday at 9 o'clock your time, to work through B from there. So thank you very, very much all.
Thanks, Gary. Thanks everyone for attending.
Thanks, Janine.
Have a great day. See you.
Bye.